Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. Today on the podcast, we're joined by Dr. Matt Sedgley. He's a physician specializing in sports medicine. He's also a fellowship trained in both family medicine and sports medicine. His special interests include musculoskeletal injuries, evaluation of non-surgical orthopedic problems, and concussions. He is a team physician for the Baltimore Orioles, Baltimore Running Festival, and Howard County Community College. Dr. Sedgley's special interests include working with runners, triathletes, and bicyclists. He has served as the primary care sports medicine medical director for several marathons and ultramarathons. He is also trained in sports medicine ultrasound. Non-operative care for orthopedic concerns and acute sports injuries are his primary focus. I've had the pleasure and honor of joining Dr. Sedgley at many races to this point. He is a wealth and breadth of knowledge, and I'm excited to host him today. Dr. Sedgley, the Sedge, we finally made this happen.
Yay.
Crazy. I am excited to host you today. I remember when you were a fellow actually sitting in sports conference and you would just spew off all these studies of like, who is this man and why is he so smart?
You're making me blush on a podcast.
We can't see you, so.
Well, that's good because I got a face made for radio, so we're all good there. But thank you for having me. I know we had to reschedule a few times, so I'm pretty excited. So ready to talk about whatever you want to talk about.
Sweet. Well, we have worked a lot of races together in the past many years, and I would love to pick your brain about emergency action planning. So, what is an EAP? How do we get started on this? Let's just kind of dig into this topic, and we'll see where we go.
Yeah, sure thing. So, thanks for having me. And for those who weren't in sports conferences with me, I'm Dr. Sedgley. I'm a sports medicine physician. I work at MedStar Health and have a lot of different roles. Some of those roles are working, with high schools, colleges. I work with Dr. Tucker at Coppin State University, historically Black College University. I also work with Dr. Sean Curtin and others, Dr. Curl with the Major League Baseball Baltimore Orioles. And I'm the director of running medicine. So if there's a race event within MedStar, I've usually either consulted with the medical director or maybe I am the medical director. But one of the other hats I wear that's kind of an extension of race medicine is I'm the co-director, of emergency action planning. So an emergency action plan is kind of a realization that you can't stop bad things from happening, but you can be prepared for them. And when we look at events, whether it's a football game like we saw with DeMar Hamlin or a lacrosse game here in town, we actually do have information, literature, knowledge about the fact that in reality, bad things are going to happen. There's going to be heart attack. There's going to be heat stroke. We even know that it's probably going to happen at a certain pace, a certain frequency. And so, with that knowledge, we should be prepared. And so I always tell people emergency action planning is just kind of getting ready for what we know statistically may occur. And then how do we lower the risk of a sentinel event or a bad outcome by being prepared? Now, there are different approaches. I think we work very closely with our athletic training staff and physical therapists and teams, whether that's a soccer club in Baltimore or a professional team in DC. They have different resources, different settings, but we try to say, we're going to right size preparation for you. And, it's kind of been nice because what MedStar Health is doing, Dr. Hudson is the other co-director. She's an emergency medicine sports physician in the South. Together, we've actually crafted some protocols. And those protocols address, again, the common things that will lead to bad outcomes in sports medicine. So we can prepare ahead of time. And when they do happen, there are recommended algorithms and guidelines so we can make sure we have the right training, the right equipment. And that way, we can't stop bad things from happening, but we can perhaps have the best possible outcome. So I tell you, emergency action planning is kind of like that quote, there's no bad weather, just bad, clothes choice in the morning. It's one of those things where, certainly there are bad outcomes. We can't stop, some people from who are smokers and diabetic and overweight who then, might have a heart attack, but we can, say, do we have, an AED within 3 minutes of, that person in the hospital or on the sidelines. So we like to think of EAPs as, getting ahead of problems, preparing for them. And then, of course, in the instance when something does happen, we like to look back and say, is there anything we could have done? We were prepared, we responded well, the patient made it, but what can we do better? I think of a hockey player that got hit in the face, was bleeding, had to go to the hospital. Both the physicians and the athletic trainer were able to stop the bleeding on the sidelines. But when we went back, they told us that all the sterile gauze in the training room was single packet. So one of the people on the sidelines was just opening hundreds of 4x4s. So he said, well, maybe we should buy the bigger packets, and just be prepared. So sometimes it's retroactive and just analysis, this kind of obsession with failure, and say, well, where could we have made this better? And I think that perspective is something that, is really needed all of our society, but also, on our sports teams. And, this is making life fun because now you can go out there and say, well, I don't have to worry. I'm 49 years old, male, might be slightly, high cholesterol potentially. I can feel like, hey, if I'm at this race, I've got, emergency room physicians at the Baltimore Running Festival in that finish line tent. They've been working closely with Baltimore Fire EMS. And, again, it doesn't stop, bad things from happening, but we can know that we're providing a safe environment so people can enjoy athletics and go out and have a good time.
And as we're talking right now, normally when people don't have their video on, they have their initials or a nice, pretty profile shot. Your picture is the protocol for emergency action planning. So we know you're quite passionate about this topic.
That's right. In fact, people are often like zooming in, trying to look at it. For anyone who is ever on a call with me, I have a protocol for what we call exercise associated collapse. If I were walking across the parking lot and collapsed, it'd be one thing, but we know a lot of, races, people run the marathon or the half marathon or 10K. They seem to stop running immediately when they cross that line and all the blood pools in their feet and they often pass out. We have a protocol for that. So I've replaced my picture of my face with that as a way of kind of putting EAP and race medicine and preparing for safety right there whenever anyone calls or does a Teams or Zoom meeting with me.
Perfect. With regards to emergency action planning, obviously an athletic trainer at a rural high school is going to be very different from, say, like a major running festival where you have all these other parties involved. How do you scale, like your planning for such events when you have no materials, and then maybe you're on a professional sports team sideline where you have access to everything that you could possibly need? How does that work?
Yeah, so I think when you see, like let's decide we're going to cover something, I think there is a bare minimum that we have to say is acceptable. No matter how much you try to right size things, we want to see it. We'll stick with cardiac arrest. Sudden cardiac arrest is interestingly a very common thing amongst athletes. It's a little bit ironic if you go to the Division 1, 2, and 3 schools and junior college schools that MedStar covers, dozens of them. Sudden cardiac arrest is actually the number one thing that kills these athletes, even though they're super young, healthy, and their doctors are maybe 2 to 3 times their age. So we have to be prepared. And I think no matter, obviously, if you're on the NFL level, they're really blessed with a lot of resources. But even if you come down to, say, a more underserved population, more rural, et cetera, we want to see that there are people that have CPR training, and that might include coaching staff. Maybe not all roles in an emergency are the responsibility of the athletic trainer. Maybe we are going to have someone who is at the football game, for example, who is in charge of opening up the gate to the fence that's on the field to let the ambulance in. Maybe we have an assistant coach who is, CPR trained, and then we treat everyone on the sidelines who's an adult as someone who's going to get that education and some basic life support, or perhaps first aid training, for bleeding, etc. We do kind of come to our partners and say, how can we help? If there's a race and they say, well, we have the municipalities around us, we can call 911, we can get fire EMS here. We'll ask the question, well, can we bring an AED as part of the package with this relationship? And so I think there's bare minimums of what we shoot for, and that may change based on the event. As you know, I cover ultra marathons that people run 50 miles, often in very rural areas. There's not a lot of resources there. But I also think there's the expectation that you're running an ultra marathon. We support races where they're 5Ks and 10Ks, where people very rightly may just do it for fun. They may not run at all. They may walk it to raise charity dollars for so many of the charities that we support, like the House of Ruth. It's not unreasonable to expect people may do that race out of the kindness of their heart to help others, and not necessarily be training, but we have to be prepared for that. So I think that there is a way that you can obviously ask the question, hey, what's our expectation? Do we want to push more resources? And so that right sizing is a conversation with all stakeholders usually.
And when we're talking about preparing for races and events, we're not just talking about the people who are participating in these events, we're also talking about the bystanders as well. I don't know if you remember, it was a running festival, and we actually took care of the Chick-fil-A mascot, who I think took a bad step.
We actually had, it was 2 or 3 years ago, someone was just walking by the race near the finish line tent and literally had a stroke. And, I'm happy to say that we had 4 emergency room physicians in that first aid tent at the finish line. We quickly were able to do a stroke alert, and I think we got him to the hospital, right away. So we were prepared for even stuff that we weren't planning for. But a little bit of flexibility and ability to improvise, whether it's the mascot for the Chick-fil-A bus or what have you, shows a readiness to be prepared. And I think that that's really kind of nice. The emergency action planning and the race medicine go hand in hand, but a good emergency action plan can be implemented anywhere. I mean, next time you're on vacation, sometimes the simplest EAP is you go to the door in your hotel and there's a map saying, hey, if there's a fire, go this way. That's a very simple written EAP for fire. And so we try to make sure that, we don't want to overcomplicate emergency action planning and make it inaccessible. We want to say, what's the most common emergency you might run into, and be ready for that. So it's, for me, as you can probably tell, I nerd out of this, I geek out on it. I have a lot of fun asking, well, what if there's lightning? What if the air quality is bad? We can develop answers for our athletic partners, our teams, our coaches, to give them advice based on the science. And that way we can kind of move forward with what's best for the student athletes.
So we're releasing this as part of a running series. So I want to pick your brain a little more about like running medicine and maybe some common things you might encounter when you're covering a race. What might like happen to an athlete who is running a race, as far as like hyponatremia, heat stroke, that kind of stuff.
Oh yeah. So I would say, we've been very lucky to basically have the opportunity to be asked by the Marine Corps Marathon, excuse me, to come in and look at their protocols. And that was one of the first things that was asked by the head of the military, Dr. Francis O'Connor, and Mark Madsen at the time. They said, what are we looking at here? And we decided that cardiac arrest was number one. We talked about exercise associated collapse, where you stop walking and the blood isn't being pumped by your calves, and pools in your feet and you pass out. That's probably number two. We also developed plans for heat stroke or hyperthermia. I was at the Boston Marathon when Des Linden won. That was a cold, rainy day. So we had hypothermia protocols for that one. Muscle cramps. Some people drink way too much water. They're not drinking when they're thirsty. They're just, there's a water stop, I'm walking the race. So they lower their salt in their blood. That's called hyponatremia. That can be problematic. We have diabetic ones with hypoglycemia. allergy and anaphylaxis in case you eat that brownie with tree nuts and you're allergic. Hydration guides. I mean, during COVID, to get the races through, we got COVID plans. We've been asked to develop a protocol for adaptive athletes or wheelchair users. And, how do we make racing more accessible, but also make it safe? So if you're not familiar with treating common injuries for adaptive athletes, we raise those common ones like, skin care, et cetera. So there's a longer list there, but those are probably the top ones we see. And, I'm sure there'll always be something that comes up this year or the next. We just had a pretty bad air quality day. We're probably going to write up an air quality one, just as a guideline that's available for anyone who needs it. But yeah, we try to push all those different protocols into one master algorithm so that if you're at a race, you can just kind of open up with a QR code on your phone all this advice, and you don't have to reinvent the wheel on race day when someone's injured in front of you. You can consult with some of the world's best experts and see what they think about that.
Two things I want to talk about that are sort of opposite of each other or not sort of related, but A, I want to know, runner comes into the tent and they're obviously in distress. What happens? And then B, to the runners who are listening, why is it so important to, I know we use race safe, but why is it so important to allow the medical, whoever's covering to understand a little bit about your history in order to help you if something happens?
So I'll answer the second one first with a story. I was covering the Twin Cities Marathon. I trained in Minneapolis with Dr. Bill Roberts, just kind of on a whim. He's like, "Hey, you want to help out this weekend?" I'm like, "Sure." And that was my first marathon I ever helped out was the Twin Cities. And that was 28 years ago or whatever it was, when I was an intern. And he's one of the grandfathers of race medicine. So you can blame him for me being in race medicine. But, they were interestingly sponsored by a biomedical company. And they said, you can run this race after you've had your pacer defibrillator placed on your chest after either major heart attack or dysrhythmia that's identified by electrophysiology cardiology. And, they didn't tell the doctors that. So I was covering, I think, mile 15-ish on the race. And we kept seeing people coming in with various arrhythmias and kept calling ambulances, and they all had defibrillators and pacers. And we ended up calling the race director halfway through the race. I'm like, man, we've called 3 or 4 ambulances for people with, pacemakers, defibrillators, et cetera. They're like, oh yeah, this race that we're really trying to get them into the race. We have hundreds of them, which, made me feel like that was, would have been information I could have used. But that particular year, and, we could have been, I think, better prepared, just at least mentally, knowing that we had a few hundred runners like that. So, there's a good example of if you have a medical condition. I'm not saying you can't run with those, pacer defibrillator. If your doctor clears you, that's great. I mean, running's a wonderful sport and probably the way forward for heart health, with exercise being medicine. But, I think if you have a medical condition and you can't speak for yourself, put yourself in the medical team. That might be an EMT or an athletic trainer or a physical therapist. Maybe you put it on the back of your bib. Hey, I'm allergic to, a medicine. Well, if you can't speak, we would want to know that. Obviously, there are software you mentioned that are out there where you can pre-populate your medical history. It's powerful to share that information sometimes, although I can understand some people, just feel like it's their business. But sometimes that's helpful. And, what we do is, to answer your first question, we have an algorithm. And, if someone comes in for medical care at a race, that master algorithm drives us into all the other, algorithms for heat, for hypothermia, for hyponatremia, cramping. Everything that we mentioned previously comes off that master algorithm. And so we start with, if the person is just, alert, are they verbal, are they unresponsive? What level of, bad, outcome are we dealing with? And if they're unresponsive, we're looking for a pulse, we're looking for breathing. Because if that's not the case, we're going off to a cardiac, algorithm pretty quickly, and they're probably leaving what I remind, everyone, it's a first aid tent. This we might have doctors in it, we might have nurses, but it's not an ICU, it's not an ED. So if you don't have a pulse and you're not breathing, you're leaving pretty quickly. If you do have a pulse, and you are breathing, but you're altered mentally, that's a big decision point for us. If you're not mentally, confused or altered, we may, have more time to discuss things with you and say, oh, we notice you're not doing well. What's going on? And you might say, well, I have asthma. I had a cold recently. I'm having trouble breathing. You're helping us get that brief history and physical while we're getting vital signs on you. If you have an altered mental status, you have a pulse, you're breathing, but you can't really, you kind of sound like me after a long day. You're not making sense. We're going to try to get, a brief set of vital signs, and, we're going to probably get a core temperature because that's going to help guide us. Are we looking at someone who actually is cold? We're looking at someone who has heat stroke. Or did you just collapse because of exercise-associated collapse or some other reason? Are you an adaptive athlete? Are we looking at some sort of autonomic dysreflexia? So we have these decision points that we quickly can go through to help guide us towards other decisions and other treatments. And that master algorithm really is kind of the entry point for all decisions at race medicine. And it's kind of nice because, either A, it can be stressful when you're covering a race and you are standing around and suddenly there's, a very sick person in front of you. Because the majority of people finish the race, they're having fun, they're with their friends. But B, you could be at a larger race. MedStar's been kind enough to allow me to travel to other races, and we're going to the Chicago Marathon this fall. We were at the Houston Marathon in January of 2023, and we're looking at their emergency action plans. And these are huge races. So when you have 20, 25, 30, 35,000 runners, you could be seeing, 5, 6, 7 runners really quickly all at once. And having that master algorithm is kind of nice because you can triage who needs to have the most resources right away, what kind of resources people need. And it's very empowering because if you review all this algorithm with your team, it can be, you can have one of your advanced care practitioners, in the tent. We have physician assistants, we welcome nurse practitioners. You don't have to have the head team doctor who's an ER doctor or a sports doctor making every decision. You can push that education down and rehearse it the day of the race before the race starts, and allow all those care members of the team in the first aid tent to help negotiate what level of care does this patient need.
Yeah, having been in the tent many years, it's when someone comes in, it's like controlled chaos. So it's pretty cool to watch everyone kind of do their thing. With regards to cooling someone down and heating someone up, what is the different strategies that are used?
Well, so let's start with heat. I think that's an important one to talk about. Hyperthermia or heat stroke, they call it heat stroke, not because you're actually stroking out, but you usually have some sort of neurologic dysfunction. So that can be confusion, you can be altered mental status, you might not be making sense, or you could have, I saw one person who had heat stroke, they were having like a very focal seizure in their arm, and their temperature was 109. So, hypothermia or heat stroke, in race medicine, we define that as 104 degrees Fahrenheit, and that's usually a core temperature, which is a rectal temperature in races. If you're with a professional team, they may have a pill you swallow that gives an esophageal or core temperature, but the other temperatures like the ear or the forehead or the mouth are usually not accurate. And so if you have those two things of 104 degree temperature and a neurologic or CNS dysfunction, we're going to call that hyperthermia. And it's important because, well, interestingly, it's not how high your temperature is. You can be 105, 106, 107, 108, 109. I've heard of cases higher than that, but it's how long you're above that 104 that really starts doing damage. And, heat stroke can basically kind of make the cells in your body not work because your cells love being at 98.6-ish. And as you go hotter and hotter, they fail to work. And so you can get liver failure, you can get, brain damage, you can get other organ failure. So we want to be very careful with heat stroke. It can be deadly. People can pass away. And so rapidly treating someone who you identify as having hyperthermia, getting off their excess clothing and initiating rapid cooling, which for a lot of our races is ice water submersion. We're trying to get them back down, below around 102, 102.5 to see if we can, get the body back in a zone where it's safer to live. The same thing goes with hypothermia, only it's the reverse. You're trying to get them above 95 Fahrenheit. Hypothermia can be deadly as well, but I think we usually here in Maryland see more heat stroke than cold patients. So I think it's important to realize that these are conditions that if we don't treat appropriately, there can be bad outcomes for the patient.
Let's switch to musculoskeletal issues. So we had Dr. O'Connor talk about stress injuries and some foot and ankle common running injuries. What are some common musculoskeletal injuries in runners that you see?
Yeah, so I think that when we look at runners, they're humans, right? So we all have our injuries, but as we kind of look at um, you know injuries that runners get, there are, I think, what I would say some more common ones that are seen. For example, you're going to have IT band syndrome. You're going to have stress fractures. There are patellar tendonitis. Plantar fasciitis. Uh, and when we talk about Achilles tendonitis, there's both kind of that watershed zone and insertional, so two different locations, which I think really should be treated as different beasts. Um, and we talk about medial tibial stress syndrome, but I lump that into stress fractures in many ways. So those are the big ones we see. It's not that you can't, um, if you run long enough and hard enough and you have say a bulging disc, you couldn't, aggravate that. But I think statistically, those aforementioned conditions are more common injuries seen in runners.
When a runner comes into your office, obviously it depends on where they are in their training. Do they have a race coming up? Their injury history. So I know there's a lot of variables, so it's not really a fair question, but runner comes in with one of these issues. How are you kind of educating them on the importance of potentially taking some rest time? And, runners don't like to not run. So it's a difficult conversation, but how do you have that with them?
So, I mean, I think, one of the things runners want to do is they want to run. And if they have a condition, that I think is going to keep them from running successfully longer term, that's something we have to have a conversation. You can't just say, oh, you have injury XYZ, don't run. You could say, for example, you have a femoral neck stress fracture. This is a higher risk, stress fracture. You need to, if it's on the tension side, which is the top, we may advise them they're going to see one of our hip surgeons. If it's on the compression side, which is on the bottom, I may tell them, look, you can't run for a bit, but that's the reason we're telling you that is because once we get you through the next few weeks of rest and rehabilitation, and we identify any extrinsic risk factors that brought you to this point, then we're going to get you back running. But if you keep running through a stress fracture, it's probably going to go from a stress fracture to a fracture, a complete fracture, and now you're not going to run for even longer. So I try to point that out and say, look, there's no discipline initially feels fun, but it's going to yield us fruits of more running in the future. So I always try to have that conversation that I'm not just saying don't run. I'm saying don't run because if you do and you completely fracture your high risk site, you're going to end up having surgery and not run for months or possibly a year. And that to me sounds a lot worse than taking a few weeks off. And it's also an opportunity to kind of just get everything right. If we, maybe this is a person who needs to look at their training. Maybe there's a training error. Maybe we sit down with their running coach or nutritionalist and we say, are we right sizing caloric intake? There's a condition called REDS. It's relative energy deficiency syndrome. Some people used to call it similar to the female male athletic triad. And essentially, a lot of stress fractures, for example, will occur through unintentional underfueling. They increase their running by 10% per week, but they're not increasing their food or energy intake by a concomitant amount. And so they get this kind of relative energy deficiency. Maybe this injury is a great time to look at, your biomechanics. We're going to get you into physical therapy. We'll do a video gain analysis. And, I don't just shut people down. Maybe I shut them down and say, this is an opportunity to take some time to optimize our training, optimize nutrition. We find people with thyroid problems, celiac disease, vitamin D deficiency. Had one person whose iron was so low, they were getting sacral stress fractures. And, I said, hey, the good news is we'll get you through this stress fracture. We'll get you some iron. You'll run even faster. You won't be out of breath. We'll drop some time. And so we try to make sure that it's a conversation that's a shared decision-making process. I think, I'm old enough to remember doctors just saying, well, Becca, you're injured and you're not going to run. I hope that's not the experience anyone has. I hope that the conversation they have with their sports physician is like, hey, you got an injury. Here's what it is. Here's the way forward. We got a plan. And while we're resting, what can we do? And that may not include running for a short bit of time, but there's a lot of stuff you can do besides running that can eventually, I think, lead to more enjoyable, more competitive running. So we try to have that conversation, and hopefully it's always well received. But a lot of us, don't like to not run, and I respect that.
You're a very busy man, I know, with when you have an athlete that has red S and there's all these other variables going on. How do you manage the interdisciplinary approach and that collaborative effort between you, potentially a dietitian, maybe a psychologist, maybe the coach, parent, etc.? There's so many moving pieces. So how do you navigate that?
Yeah, I think that's a great question. Certainly, it's nice sometimes when there are a lot of resources surrounding those injuries. A multidisciplinary approach is always my recommendation. I do have some go-to registered dietitians and nutritionalists. And, I tell runners, like, for the cost of 2 pairs of shoes, you might get a relationship with somebody who can email you, like, hey, I'm traveling. I've got, this and that that's in my world. I'm having trouble eating as I go through, I'm going through med school, or, I've recently had a baby, like, where I'm trying to lactate. Partnering with people who have stress fractures with a multidisciplinary team, I think, is absolutely critical. We're going to be involving our physical therapists. We're going to be involving, if they're with a collegiate or high school team, their athletic trainer. We want a nutritionalist. And look, a third of the population has some level of, mental illness, and that can be depression, anxiety. And I take away running. Let me tell you what, we may need to touch base with their health psychology team. We have to be very honest with ourselves that running plays a role that I think helps a lot of people deal with stress. And if I'm going to temporarily take that stress reliever away from people, we may have to access, a team that can help people deal with that. Look, in a severe case, I've had marathon winners, people who are winning races, get a stress fracture who need surgery. We're going to have to talk to their surgeon and say, look, what kind of surgery are we doing here? What's our recovery? What's our chance of, success of getting back? It really is something where you shouldn't ever have to manage these injuries as a patient alone. And I would encourage other, healthcare providers, if you're addressing the needs of runners and, you identify that they have maybe some relative energy deficiency, or their laboratory data is off, or you want to get a consult with one of our, MedStar has some amazing sports surgeons. Say, look, we're just going to take a one-time conversation with them and see if this tibial diaphyseal injury is something that, we don't want to waste your time. It really goes well. I think patients enjoy having that, ability to consult with expertise and then circle back and say, okay, here's the best plan moving forward.
Yeah, that makes a lot of sense. And one thing I didn't cover so much with Dr. O'Connor with regards to the foot, but you brought up plantar fasciitis. And as a PT, this can be a bear to treat. And oftentimes runners are coming in with a year, 2 years history of this, and they've tried bracing, anti-inflammatories, just all the things. What's your course of treatment for someone who has plantar fasciitis?
Yeah, so for those who don't know, plantar fasciitis is kind of a difficult condition that we see. A lot of times it is this really sharp pain that's on the bottom or plantar surface of the foot. It's often worse after you've been sedentary, seated, or laying flat, first few steps in the morning, just a sharp pain. And it often is kind of multifactorial. A lot of the times the morphology of the foot plays a role. Flexibility of the posterior chain or muscles like the glutes and hamstrings and calf muscles play a large role. But in the end, unlike a true, like if I run too far today, let's say I go to do 10 miles and I'm only due to do 5, I can get a tendonitis and I'm sore for a few days. Plantar fasciitis is one of those injuries that is similar to a chronic tendinopathy. Usually you kind of bruise for a little bit before it happens. And if you look at the actual tendon on MRI or under biopsy, it's actually more of a tendinosis. And so the tendon's been under stress for a while. And because of that, it lasts a very long time and can take a while to go away. I think that depending on your perspective, some people are very big into orthotics. Some people are not. Stretching, I think, is universally thought to be a good approach, and I try to have the entire posterior chain addressed. I'm a big fan of other modalities, including, but not limited to, Graston, ASTEM, manual therapy. A lot of trigger point injections or dry needling in the calf can be helpful. And so having a physical therapist who's very comfortable addressing this condition, I think is key. You got to also look at how people are running. Getting a video gait analysis is key. Sometimes it's not anything you're going to see seated in front of the patient. You need to actually look at them try to run. And it's frustrating, but there are some literature and some data that possibly injecting things in the tendon could be helpful. Now, in the old days, I remember giving cortisone shots in the plantar fascia 20 some years ago. It's just not what we do these days, because there are some concerns that people who rupture their plantar fascia, a lot of them actually have had a cortisone shot. And so the cortisone may be weakening the tendon there. It seems like, the trend has been to go to more orthobiologicals, such as platelet-rich plasma, where they take some blood, they spin down your blood, and they take the platelets and inject it. There's also some other orthobiologic conditions that, or treatments that we'll see people do, such as there's some placenta-based proteins, but essentially these are often not covered by insurance, which can be a limiting step. There's some exciting new data on shockwave therapy. I think it's probably underused for tendinopathy, although it can be painful. And then there's some newer stuff coming out with electromagnetic treatments, and those are always exciting because, like you said, plantar fasciitis is just a pain, and it can take a long time to go away. Sometimes these modalities are cash only, which I hate to even mention because, I wish it was just accessible by everybody, no matter, what their socioeconomic situation was. But, these are exciting things that I think that when we look at plantar fasciitis, kind of doing an all-in approach is finding out what works for everybody. For me, I did a lot of cortisone shots 20 years ago when I had it. It worked temporarily. I went to PT once. They really dug into my calves and found some trigger points, and I never needed another shot. So I think partnering with a good physical therapist is critical for this particular condition. My general sense is, there are other things we can try if that's not successful.
Definitely. I know we could talk about this stuff all day long, and we've covered a long list of topics on this all over the place. That's okay. Is there anything else with regards to running medicine that we didn't talk about that you would like to talk about? Or that you think is important for our audience, which are mainly PTs, PT students, etc.?
Yeah, I think I always encourage people to get out there and volunteer. If you think about it, when I was but a young lad and like around 29 years old or so, and I volunteered for the Twin Cities Marathon, I had no idea that this would take me on this odyssey of where, I've traveled all across the world to cover races. I mean, when people are like quoting Professor Sharma out of the London Marathon, yeah, I've met him. I volunteered his race. I shadowed him in 2010. It's an odyssey, and it's really fun. And I don't think that would have happened if I hadn't said, you know what, I'm not going to sleep in on this Saturday. I'm going to go volunteer for this race. So it's the people you meet, it's the relationships, and I would encourage people to get out and volunteer. It's amazing how that can make you feel good. I think we all probably had a little bit of the opposite feeling during the COVID pandemic, where we were not interacting with people and we were told we couldn't, do sports, couldn't hang out. This is the time where, look, no one gets rich volunteering at a race, but maybe the only thing that, you should focus on isn't, how much money's in the bank. You should say, how's that going to make me feel? And I love seeing the volunteers. We wake up, we often have, some coffee there. We chat, we hang out. I mean, Becca and I, this is how we kind of spent some time together a few years ago. And you build relationships. And to me, that's really important. So I think it's important to give back to your community. And this is an easy way to do it, because a lot of times a race is like a 1-day event. It's a few hours. Unlike some things in sports medicine where you're doing it daily or weekly or yearly. This is something where I think it's an opportunity for you to explore it. And maybe you do it and you're like, it's for Dr. Sedgley. But, I think it's nice to see the faces of the runners while you're clapping for them, cheering them on. And that makes a big difference. So I would encourage people to volunteer. And, maybe that's not what you want to do. Maybe you're like, forget it. But, don't knock it till you try it. Give it once. We have tons of races year round. We can always find a way for you to give back in any role that you're interested in.
Beautiful. Well said. I know, I'm sure you can share in the sentiment, but there's nothing like seeing your patient cross that line when months ago, weeks ago, you were with them and they were maybe crying in your office and not thinking it was even a possibility that they would make it to toe the line. So it's just an incredible feeling to be in that atmosphere.
It really is. And, my general sense also is that, if you do end up liking, giving back, we have the ability to make this, a larger part of, who you are. I always, feel like running is very accessible. I think that, the beauty is you can have those folks who are crossing the line, running those incredibly fast, miles, or you can have the folks who are just getting over their third bout of cancer, and they're going to be happy to finish right before we all close up. To me, that's a beautiful thing. This is a sport where, if you're willing to put on your shoes and go out there, we're going to accept you. So like everyone's welcome. And that's a really good feeling.
Love that. It's a beautiful way to end and start to wrap up. We like to end our episodes asking your favorite quote. So Dr. Sedgley, what is a quote that moves you, drives you, inspires you? Doesn't have to be medicine related, but what's your favorite quote?
So I'm the director of running medicine. So I'm going to give you a running quote. And it's coming from Kara Goucher. She's an Olympic long distance runner and bronze medalist for, and also is, from the Boston Marathon. And I think she's a leader in our society, speaking against injustice and very, telling people to get out there and represent themselves. So her quote is, "It doesn't matter how fast or how far you're going. If you're putting on your shoes and going out for a run, you are a runner. You are in the club." And so we'll kind of end with that just quote, because she's a wonderful person. I've gotten the chance to meet her briefly. Phenomenal person if you know her life story. And I think that quote is just so inclusive, and it kind of speaks to me. And hopefully, you feel welcome to come out and help at a race sometime. We'd love to have you.
Love it. Dr. Sedgley, where can people find you?
So I work at MedStar Health. I am at Ellicott City. I'm in Frederick. I'm in Westminster. There's not too many ways to spell Sedgley. If you type that in with MedStar, you'll find our numbers you can reach me at. I also am volunteering as team doctors at Howard County Community College and Coppin State University. And then there are, I think we're up to 14 races year round that I'm at. So if people want to see me as a patient, great. Come see me. Look me up on MedStar's website. If they want to volunteer with me, reach out. We'll post an email where we can get a hold of me if you want to volunteer. But I appreciate the opportunity. So thanks for inviting me on.
Yeah, thanks so much for being here.
You got it. Take care.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.